So good afternoon, everyone. Today my topic is going to be hybrid ECMO and nomenclature of an ECMO here. So myself, Dr. Rakesh V, Clinical Director, Critical Care and Anesthesia. It's NASA Group of Hospitals from Hyderabad. So next few minutes, I'm going to take you about how we are going to nomenclature, how we are going to name a patient on ECMO, especially here. So why naming of ECMO is actually important is only for universalization of all the techniques which we generally use and for proper communication in between the patients and proper communication in between the doctors also here. So let's go into the topic. Let's see the various types of ECMO which we generally have. We have VA ECMO for our cardiac patients. We have VV for our respiratory patients. And we have hybrid ECMOs where there's a combination of both cardiac and respiratory ECMOs. It might be V-VA or VAV, or it might be VVVA or VV-AV. And there are some variants of ECMO where we are adding one more extra cannula to the basics of ECMO here. So it is depicted as VV-V or VV-A here. So one more variant of ECMO is there. It's called cord removal, or you can also call it as AV cord removal for ECMO here. So this is a gross slide showing the various types of ECMO here. Coming to the physiology of VA ECMO, as we all know by this point of time, it's going to support the heart, VA ECMO, and VV ECMO is going to support the lungs here, and VA ECMO supports both the heart and lungs. So I'm not going in detail of the physiology behind the VA and VV ECMO, so I'll stick on to my topic here. So hybrid ECMO and variants of ECMO. Is there any difference between these two? Yes. Hybrid ECMO is a modified form of ECMO where two modes of ECMO has been combined. VA and VV combined together, we call it as a hybrid ECMO. And coming to the variants of ECMO, so these are the modes of here essentially the ECMO modes remains the same, but there's only thing that is getting added is your extra addition of a vascular access or extra addition of an equipment that is being used. That is called as a variants of ECMO. So what are the other variants of ECMO which you generally have? As I'm quoting earlier, we have a VAV ECMO, we have VVA ECMO, we have VVV ECMOs, AVCOR and ECOR2 kind of ECMOs here. So we'll deal with each and separate type of ECMOs in detail along with their nomenclature and how they're going to be, how we are going to name this particular set of ECMOs and what are their indications, outcomes and incidence of hybrid kind of ECMOs here. So coming to the nomenclature part for extracorporeal life supports. So why do we need nomenclature here? It's only to standardize the things here. It is better understanding between the caregivers, better possibilities for research and studies. So to do this, ELSO came with a nomenclature task force. So wherein they have come with different definitions based upon the literature and how to do the nomenclature here. So they came out with some set of rules here while you're naming any kind of ECMO here. So wherein the drainage and return cannulas, which you generally have been separated by a hyphen here. So the prefix of the hyphen, which is the left side is a drainage cannula. The right side of the hyphen is going to be your return cannula. So don't be confused between the venous and arterial cannulas here. So when the minute I say drainage cannula, it's a venous drainage cannula. The minute I say return cannula, it might be a venous return or it might be an arterial return depending upon the type of ECMO. Either it's a VV or a VA kind of ECMOs. Coming to the additional cannulas, like the modifications which we are doing, which I have told you prior. If the modification is done by means of a minor flow, it is labeled with a small letter. And if the cannula modification which are done is a major flow, you can call it, you can name it with a capital letters here. They're generally done for secondary drainage and unloading of specific anatomical locations, like LV unloadings when you are going to do, or when there is a pulmonary hypertension, unloading of your pulmonary arteries in those specific situations, and distal perfusion cannulas or the venous drainage too. Okay, and if the drainage, I mean, if the extra cannula which you are adding is major cannula, then it is labeled with a capital letter. Okay, so if I say VV-V, so it might be V small v hyphen V, or it might be V capital V hyphen V. Small and capital letters depicts the flow inside the cannulas. If it's a minor flow, it's a small letter. If it's a major flow, it's a capital letter here. So one more nomenclature rule is whenever you're using a double lumen cannulas for a vena-venous ECMO here, DL should be added as a prefix here. So you should add DLVV. That means it's a double lumen cannula and it's a VV kind of an ECMO here. So vessel cannulated again. So once you've done these things, you need to add the vessel that is cannulated also at the end of the drainage cannula or at the end of the return cannula also. It is subscript in the form of lowercase letters. Say for example, if it is VF-AF, that means it's a femoral kind of a VA ECMO. Or you can see the second example, it is VF-VJ. That means it's a femorojugular kind of a VV ECMO here. So the drainage and return cannula names remains the same. And then the vessel that you're going to cannulate should also be labeled in a small letters here. So let's see how many, I mean, like what are the various kinds of vessels you do have for the cannulations here. For a primary axis or a secondary axis, if you're using a systemic artery, capital A, if you're using as it as secondary axis, small a. If you're using a systemic vein, capital V. If you're using a pulmonary artery, capital P. This is the axis part. It's like VV or VA or VPA or VV hyphen V, something like that. So coming to the cannulation site, how you're going to incorporate the cannulation site in the nomenclature. Based upon the vessel that you're using, if it is a carotid artery, that is VC. So I mean, sorry, it's AC. If it is a femoral vessel that you're going to cannulate for a VV ECMO, it is VF hyphen VF. It's a femoral kind of VV ECMO here. Jugular veins, small j, subclavian vessels, it's small s. If you're using a central cannulation size, don't forget one important point here. If it is a central cannulation kind of an ECMO, the chamber that you're cannulating should be labeled with capital letters. That too, two letters. It's the right atrium, it's RA. Left atrium is LA, LV is your left ventricle, aorta is AO, pulmonary artery is PA. The minute if I see the ECMO is like V capital RA in the bracket, that means that it's a central kind of ECMO. That is to be understood here. So that's the importance of the nomenclature. By just seeing the nomenclature of the ECMO, you need to understand where is the cannulation site, whether it is central or a peripheral, and what is the cannulation vessel you're going to do. So whether it's a femoral vessel or a carotid vessel or jugular vessel, and what is the configuration of ECMO? Is it VV or VA? So that's the importance of the nomenclature here. So hybrid ECMO, as I'm telling prior, it's a modified form of ECMO where two ECMO modalities has been combined here. It might be VV converted to VAV or VVA, or it might be VV converted to VV hyphen VA or VV hyphen AV. So the importance of hybrid modes of ECMO is they support both heart and lung. So the indications will be or like both combined. I mean, it's like multi-organ failure where there is severe ARDS leading to viral myocarditis, or it might be severe cardiac stunning leading to ARDS. So wherever by the situation that is getting affected with both of your lung and heart, you need to go with the hybrid modes of ECMO. So mostly required during an ECMO run, but can be planned from the initiation also. So one more important thing is you might get a doubt that how to start an ECMO here. If I find a patient who is having a severe ARDS with viral myocarditis, so whether I have to go with an hybrid ECMO prior or I want to go with a natural ECMO, then converting it to a hybrid ECMO later stage. So it depends upon the patient and clinical situations. So if the patient is completely devoid of your cardiac and respiratory functions, you can directly start with a hybrid mode of ECMO also. Even that's also indicated. And if the patient is literally stable, it's having a single organ failure, start with one modality of ECMO. And if they lands in complications, yes, convert into hybrid ECMO here. Like the example which I quoted here, whenever a cardiac patient on VA ECMO requires lung support or a respiratory patient requires cardiac support, yes, hybrid ECMO is initiated here. So there is one more nomenclature called variants of ECMO. So these are nothing but a basic modality of ECMO. Here the VV or a VA ECMO remains the same. But what changes is the vascular axis. Say for example, in a VV kind of an ECMO, if I add one more vascular axis of drainage, that becomes your VV hyphen V. In a VA ECMO, if I add one more vascular axis for drainage, that becomes VV hyphen A. That means it's a major drainage I'm adding on the vascular side. So this is called as a variant of ECMO, wherein your modality of ECMO remains technically the same, but only thing that is changing changes the number of vascular accesses. So two venous vascular access has been established here. That is called as a variant of ECMO. Ecor removal, as we all know, it's an AV core kind of an ECMO. If you can observe here till now, we are talking of VV, VA and kind of thing, but here the prefix is AV. That means it drains from the artery and gives the blood in the vein. That means it's like an AV, A hyphen V, carbon dioxide removal ECMO. We can also call it as pumplex extracorporeal lung assist because it's draining from the artery and giving back to the vein. There is no need of an extracorporeal pump, just like for ECMO. If the people who has done ECMO, some ECMO experience, if you have seen a proper AV cord circuit, it just comes with a circuit with a what do you call it? A simple oxygenator inside that, wherein the pump is being at the native heart. So the prerequisite for establishing your ECOR circuit or prerequisite for establishing an AV core kind of an ECMO is your heart should be properly functioning. So heart acts as a pump. From the artery, the blood goes into the circuit, and from there, the carbon dioxide removal happens in the oxygenator, and then the decarboxylated blood is being given back to the venous side of the patient. That is called as AV core. We can call it as ECLA, a pumpless extracorporeal lung assist, and ILA, interventional lung assist also. There is one more modality of ECOR removal, carbon dioxide removal. It's nothing but a VV ECMO where you are using it only for the carbon dioxide removal. Say, for example, VV ECOR. That means a simple VV ECMO you are using mainly for the carbon dioxide removal. You can call it as VV ECOR. And there is an Indian jugaad or a hybrid model of this VV ECOR also, wherein you are cannulating two veins by using a simple dialysis catheter and then using a pediatric oxygenator. You can do the carbon dioxide removal, provided your oxygenation is very much good in this kind of settings or in this kind of indications here. So ECOR can be planned in AV kind of a situation or a VV kind of situations too, depending upon your patients here. So let's see this VV-V kind of an ECMO. As I'm telling earlier, it's not a hybrid ECMO. It's just like a modified ECMO, a modified VV ECMO where the additional drainage cannula has been kept here. If you can see the diagram here, there are two venous drainage cannulas from the femoral vein and then one more drainage cannula from the jugular veins. Okay, that is being oxygenated and the blood is being given back again into the femoral vein here. So it's a VV kind of an ECMO here. What's the reason for establishing this kind of ECMO? Whenever you find a refractory recirculation, so you need to get more flows. In those situations, adding an extra drainage cannula is going to decrease your refractory recirculations and also for additional drainage. If the cardiac output is pretty much high, you are unable to reach the cardiac output with a traditional VV ECMO. In those situations, it's going to help you. And remember, it's a simple VV ECMO. It's a lung support ECMO. That's it. Coming to V-A ECMO. As I said earlier, it's a simple cardiac support ECMO. It's technically a VV ECMO wherein you're adding one more drainage cannula. That's it. So one more drainage cannula has been added in the jugulars. So that drains again from the femorals and jugulars and goes into the artery, femoral artery. The reason for establishing this kind of ECMOs is better drainage of RV. Whenever there is a heart failure, that is right heart failure, especially setting in a case of VA ECMO, in those situations, yes, for the better drainage of RV, you can go for VV-A kind of ECMO. Once the heart recovers, you can wean it back to VV mode of ECMO and then afterwards you can completely wean off the patient right here. So let us see what are the various indications for these hybrid modes of ECMOs here. It was already discussed prior. It has like combined heart and lung failures. A septic shock with ARDS patients. Whenever there is severe ARDS with inotropic score more than 100, a myocarditis with ARDS, say for example, a dengue viral myocarditis with severe ARDS like dengue 1, H1N1. In those situations, yes, in the initiation phase itself, you can directly go with the hybrid modalities of ECMOs like VAV ECMOs here. If it is a VV ECMO, what are the various situations which warrant us to go into VAV ECMO? In a VV ECMO, when there is a cardiac arrest that happens during a VV ECMO run, yes, you need to immediately convert it. You cannot remove the venous cannula that is already cannulated or venous return cannula is already cannulated. So better in those situations, if you're having a cardiac arrest kind of scenario, convert it into V-AV kind of ECMO. Whenever the patient's cardiac status is deteriorating, if the patient is on a VV ECMO, like situations like RV stunning, severe pulmonary hemorrhage and pulmonary hypertensions, septic myocarditis kind of situations, you have to convert from VV to VAV. Unstable hemodynamics, simple. Septic shock during an ECMO run. Refractory hypoxia when there are high lactates and unstable urine output kind of scenario and acidosis, severe acidosis that is being setting in those situations, you can convert VV to VAV. So let us see what are the indications where VA can be converted into VAV. That means a VA ECMO is actually a cardiac support ECMO. In a cardiac ECMO, whenever your lungs get deteriorate, that means your north-south syndrome is getting settling in. In those situations, you have to convert your VA to VAV ECMO because technically what happens when the heart starts recovering on a VA ECMO, it starts pumping blood from the native lung. So when the native lung also got affected with by terms of any VAP or ARDS, that means you'll be getting a deoxygenated blood from the native lung that passes from the upward side of the aorta and an oxygenated blood from the lower part, which comes from the ECMO machine here. So when there's a mix of these two clouds, there will be a north-south syndrome where the upper half of the body will be perfused with deoxygenated blood and the lower part of the body will be perfused with hyperoxygenated blood. So in a VA ECMO, whenever there is a cardiac recovery slightly happening with a lung deterioration, yes, we need to convert from VA to VAV. Cardiac stunning, even for cardiac stunning situations, for achieving better coronary perfusions, we can go for VAV. And the most important indication is to decrease the neurological injury. You can go for a VAV kind of ECMOs here. That's the basic indications here. Coming to some statistics, what's the reason for hybrid ECMO? And hybrid ECMO, the advantage is biggest advantage. It ensures your heart, I mean, like cardiac and cerebral perfusions here. If you see the statistics from ELSO here, so as the blood flow has been increasing the venous blood flow, there is a saturations improvement. The saturations in different parts of your heart, inferior IVC, pulmonary artery, left ventricle, and abdominal aorta, has been plotted in this graph here. If you can identify the circles here, as the flow is gradually increasing, the venous blood flow from 0 to 10 to 20, 30 is gradually increasing in a hybrid mode of ECMO, what I'm talking of here. Your pulmonary artery saturations are technically increasing from 62 to 96, and your left ventricle saturations are increasing from 70 to 96 here. So in a hybrid modality of ECMOs, if you increase the venous blood flow, I mean the blood flow into the venous part of the limb, that means that you're indirectly improving the saturations in the LV and the pulmonary artery. That means the saturations to the whole body. If the LV saturation improves, a very good means that means our whole body saturation also improves. So let us see these hybrid setups of ECMO. As I said earlier, there is one more ECMO called like in a hybrid ECMO like VAV or VVA. What is the difference between these two? Which letter has to be kept first and which letter has to be kept later on? So in a hybrid ECMO, VAV or VVA, whatever you call, it's a hybrid ECMO, which you all know. But the only thing that differentiates the main part of it is the initial part. If it is VV converted to VAV, that means you need to keep it as V hyphen V and then A in the last. And if it is a VA ECMO converted into VAV, that means V hyphen A and then the venous has been added later. So if I see something like V hyphen AV ECMO, that means I can understand the patient is on a VA ECMO and then his lungs got deteriorated, then it converted into V hybrid ECMO called VAV ECMO. Now, next thing is if I see VVA has been written in the case sheet, that means to my understanding and to everyone's understanding, it's a VV ECMO to start it up with, and then it has been converted into V hyphen VA ECMO because his cart has got deteriorated in the later stage. So the written cannula, which is being added after the hyphen, should be given in the last place. That means, as I think you understood that point. So it supports both heart and lung here. So, and there is one more modality of ECMO which we are discussing prior also. It's called as VV-VA or VV-AV. It's the same thing. Only thing what you're seeing the difference is one more venous drainage cannula has been added here. If you see the diagram here, you're draining from the femorals, you're draining from the IJV and giving blood back again to the femoral artery and femoral vein if it is VV-VA. Or if it is VV-AV, again the same thing happens. So whichever is added at the last, okay, the same thing. It's a VV-V ECMO converted into VV-VA, or it's a VV-A converted into VV-AV. So whatever might be the nomenclature, just the extra drainage cannula which has been added here should be added on the before the prefix, and the written cannula extra which is added here in the circuit should be added after the prefix. Okay, so it will be two drainage cannulas. I mean, like two output cannulas, one in the artery, one in the vein. That's it. It supports again both heart and lungs. So configuration based upon the vascular access, which I'm trying. So what are the various vascular access which we generally have? We have a double lumen right IJV and then subclavian can be done. A double lumen right IJV and femoral artery can be done. That's called as a sedate hybrid. A femoral vein and femoral artery or a right IJV can also be done as a configuration part. Pulmonary artery is one more important artery. You should consider it when there is severe pulmonary hypertension. I'll tell you in detail about the pulmonary artery cannulations. Left atrium with the transeptal approach. So these are the various configurations and vascular access that are available. So this is the nutshell of all what we're discussing till now. Coming to the diagram, can you see the first diagram? There's a two venous drainage cannulas and then artery. That means it's technically a VA ECMO, one more drainage cannula. Coming to letter B, it's again the same VV-A, but the only thing is two femoral drainages here. It's a femoral and jugular drainage here. Two femoral drainages and an arterial return. Again, the third one, it's a VV-A again, but it's a double lumen VV here. So drainage is both from the IVC and the return into the artery. So A, B, and C are technically the same. Only thing the drainage sites has been changed. That's the reason why you should mention that the small letter. Say for example, A, you need to add VF and then VI followed by AF. So they can understand what is the drainage sites here. Coming to the D, VAV ECMO, which I have discussed. Venous drainage from the femoral vein and the return into the jugulars and return into the femoral artery tube. Again, D and E. VAV, it's again called VAV, but only thing is the venous drainage instead of femoral from D, with the diagram D, the drainage is from the jugulars here, and then the return is again back into your IVC and the return is back into your femoral artery also. So that's a VAV kind of ECMO here. And then coming to letter F, you can see VV-AV, two drainage cannulas, two return cannulas. The two drainage cannulas are femoral here in this diagram, and then the two return cannulas, one into the femoral artery, one into the jugular vein. Coming to this diagram, it's a again VV-AV. The two drainage cannulas, you can see one is from femoral, one is from the jugular. Return is to the femoral artery and femoral vein. So coming to the H configuration, which is very rare, it's a VA kind of configuration. If you're unable to achieve the venous flows from one limb, so they tried draining from all the major vessels that is available in the body. Two femorals, one jugular. So all the major vessels has been used for the drainage. That is V hyphen A kind of an ECMO here. So hope everyone understood this diagram here. So this is the double lumen right IJV and then subclavian artery cannulation, which we call as a walking hybrid kind of an ECMO. It is usually done in patients awaiting for transplant. Say, for example, if the patient is awaiting for a lung transplant or a cardiac transplant. So in those kind of situations, what we do, we use a double lumen cannula placed into your IJV that helps in the draining, and the return cannula that goes into your pulmonary subclavian artery. So it can be used usually done in patients awaiting for transplants here. You can do double lumen right IJV femoral artery. It's called as a sedate hybrid. That's a walking hybrid. This is a sedate hybrid. It's generally done for conversion from VV to VAV kind of an ECMO here. You can also do it from the initiation part also. See this configuration. This is a configuration where we call it as VPA configuration. Technically, it's a VA ECMO, but the return is in the pulmonary artery. That's why we call it as a VPA configuration. It's not that common to see. It drains from the right atrium and returns into the pulmonary artery. So it's a kind of a right heart support kind of a device. Technically used in severe call-pulmonary or severe right-sided hypertensions or right-sided heart failure kind of scenarios here. So what are the advantages of VPA cannulations? Like your right atrial pressure decreases, your pulmonary artery pressure increases. That means the perfusion to the lungs will increase. Left ventricular end diastolic pressure might increase because you're giving the blood directly into the pulmonary artery. Systolic blood pressure will improve. The vasopressor dose might decrease and inotropic dose might decrease here. It's technically a right heart support. You're bypassing the right ventricle, sucking the blood from the RA and giving it back into your pulmonary artery here. It's not a central cannulation, guys. That's why we call it as a VPA. If it is a central cannulation, you need to write RA-PA. So as I told in the first slide here, central cannulation should be depicted with two capital letters. So it is written as VPA. That means it's a peripheral cannulation. And it's a venous. That's from the right atrium. And then pulmonary artery kind of configuration. So there's one more cannula called as Protect Dio cannula, which serves the same purpose. So if you have to go and read, you read about the Protect Dio cannula, or it's also called as tandem heart. See this configuration here. It's a VAPA configurations. So drainage is from the vein, femoral vein, and the return is again what is happening? One is going into the femoral artery, one is going into the pulmonary artery. So technically, it's like a VA ECMO. When the right side of the heart gets failed, what happens? They convert it from the VA ECMO to VAPA ECMO. So that's what is depicted here. So V-APA, that means VA to start up with, and then they cannulated the pulmonary artery in the later stage. So what are the advantages of this VAPA configuration? Again, the right side atrial pressure decreases, pulmonary artery pressure increases, left ventricular end diastolic pressure will increase. So that helps in increasing your systolic blood pressure, decreasing your vasopressor inotropic dose here. So one more hybrid ECMO where you have to do a transeptal punctures here. So where do you do a transeptal punctures in a hybrid modalities on ECMO here? So let us see what are the various situations where you do a transeptal puncture. If it's a patient on VV ECMO, so when do you do an atrial septostomy? So you do it when a VV ECMO, you're unable to achieve the saturation levels. When there's refractory hypoxia, when there's severe pulmonary hypertension that is setting in, either because of pre-existing core pulmonary or because of a PTEs or a subsegmental PTEs or because of any chronic hypoxia leading to pulmonary hypertensions. In those situations, what happens? Even the patient is on a VV ECMO, technically the blood flow is not reaching to the native circulation of the heart. So it's like a shunt that is happening on the venous side of the body. The remaining blood supply, which is supposed to reach to the right side of the heart, to the pulmonary arteries, and from the pulmonary arteries, it should go to the left side of the heart. Because of the pulmonary hypertension, it's not going into the pulmonary arteries. So in this kind of scenarios, what we generally do, you will plan for a VV ECMO, and then we'll do a atrial septostomy so that the venous side of the heart, which is being, which is being perfused with the hyperoxygenated blood, will pass to this atrial septostomy into the left side of the circulation here. So VV ECMO with atrial septostomy is generally done when there's refractory hypoxia or pulmonary hypertension here. See this second type of configuration, V-VLA ECMO. That means it's a VV ECMO, and then there is a return cannula that means placed in the left atrium. So you do a transeptal puncture and place a left atrial cannulation also you do it off. So instead of just depending upon the transeptal puncture, you place a cannula in the LA and give the blood into the LA. So technically the indication is the same, but only thing is you're adding a cannula here. So instead of septostomy, We are doing septostomy plus placing a cannula. That's it. That's called as V-VLA. The indication is again the same, refractory hypoxia or a pulmonary hypertension. See this modality of ECMO. The LA came to the prefix. That means it's a venous drainage. That means it's a VA ECMO to start up with. Then they added LA drainage. So they did a VA ECMO and then the transeptal puncture and then LA cannulated to drain here. So what are the various situations we'd see this LA drainage type of cannulas? This is called as lava ECMOs. Recently, this came as a nomenclature called as lava ECMO. So when we start up the case with a VA ECMO, when a severe heart failure, when the heart starts improving, or when the heart is still not improving or cardiac stenting with LV distension happens, that means your LV will be properly distended completely with a VA ECMO because of increased afterload. That will transfer, that will transfer the pressure from LV to LA. That will lead to pulmonary hypertensions. That will lead to pulmonary edema and deterioration from the lungs also will happen. So in a VA ECMO, when there's a cardiac deterioration because of non-functioning of the heart, you might go with IABP, you might go with inotropic supports. All the medical management can be done. If that is not improving, you can do a transeptal puncture and place LA drainage cannula. Okay, so that's called as in lava ECMO, generally done for LV distension in a VA ECMO kind of scenarios here. So don't be confused here. Just because of the nomenclature, you can understand what is the indication, how the modality started, and how it ended up at present here. So this hybrid ECMO transeptal configuration, just anything can be possible. You can have two drainages, RA and LA. Both can be used as a drainage. LA drainage is for LV distension, and LA return is for mainly pulmonary hypertension. Return is again femoral and subclavian arteries can also be used. So let us see the data of hybrid ECMOs here. So this data is from 2017 to 21. If you see the data from adult population, pediatric population, and neonatal population, the percentage of hybrid ECMOs are pretty less if you compare to normal basic VA ECMOs here. And if you see the survival percentage, 38% of hybrid ECMOs has been survived in adults, 36% of hybrid ECMOs has been survived in pediatrics. But when it comes to hybrid ECMO in neonates, it's 78%. So if you see, the zincs of the totals, this slide is 1 to 2% of these routine ECMO patients require hybrid variants. So they'll have different kind of organ failures mixed together. But the survival benefit is only seen in neonates. So there is no survival benefit in adults and pediatrics when you're using for a hybrid modality of ECMO. But it doesn't mean that hybrid ECMO is not going to help you. It will definitely going to help you, provided what are the various things that are required for for the outcomes of hybrid ECMO. I'll tell in the detail because it's a complex kind of a procedure. You need to have technical expertise here. Coming to the cardiac ECMO converting into a hybrid ECMO. Okay, again the same thing happening here. If you see the the mortality benefit of the percentage of the people survived on a cardiac ECMO with a hybrid mode conversion is 42, 59 in case of pediatrics, and 40% in case of neonates. So again here, cardiac ECMO being converted into hybrid is little bit higher. 3 to 5% of the patient population is requiring the hybrid ECMO mode, but survival is again at par with the neonates here. So in adults, pediatrics, and neonates, the survival rate is actually good when it comes to outcomes of hybrid ECMO. So VA ECMO converted into hybrid is better outcomes compared to VV ECMO converted into hybrids here. Let's see this eCPR data. If it's in eCPR data, again, the adults, pediatrics. So eCPR data, 2% of the patients are requiring eCPR hybrid modality of ECMO. When I say eCPR, it's a VA ECMO, converting into V-AV kind of an ECMO here. So in a VA ECMO and eCPR, around 2% of the patients are requiring conversion to VAV ECMO, either because of lung failure that is happening or because of north-south syndromes. There might be several indications, but survival is again at par with the neonates here. So if you see the total statistics, the neonatal survival is pretty much good. So neonatal survival is always good when it comes to ECMO. So hybrid ECMO is not an exemption here. The total survival percentage of chances is around 39.82% here. So there is one study from University of Michigan where they have done 31 runs of VVA ECMO in adults and pediatrics. So again, the median PF ratios is 53%, around 50 to 55 PF ratios prior to cannulations here. So let us see the outcomes in those particular part. So if you see the outcomes in that, percentage of time and the outcomes of hybrid ECMO in Michigan experience, if you see that the reasons for converting a VVA ECMO in pediatric population is mostly because of north-south syndrome, and in adult population is mainly because of cardiac failure. That means a VA ECMO is being converted into VAV in pediatrics. Okay, and VV ECMO is being converted into VAV ECMO in adults here. So that is the take home message from this particular point of slide here. If you see the survival, pediatric survival is pretty much good, and adult survival is little bit around 40 percentage here. And the chances of complications has been given here is nearly almost equivalent to routine ECMO. So why it is technically challenging to achieve the outcomes when it comes to hybrid modalities of ECMO? Because you need a lot of expertise, you need a lot of equipment. So the equipment which is shown in the figure is called as Hoffman's clamp. It is generally used to adjust the flows in different limbs. So when you have two drainage cannulas, when you have two return cannulas, one in the artery and one in the vein, how you are going to adjust the flows? By using this Hoffman's clamp. So what you're supposed to do in a VAV ECMO, you're supposed to clamp the venous line partially is required. Why? Because venous vessels will have less resistance. So more blood flow technically goes into the venous line rather than going into the artery. That means your heart is being less supported and your lung is being more supported. So to prevent that thing, we'll partially clamp the venous lines, adjust the ratio of the flows to the vein to the artery. So you need to adjust the flows according to the requirement of the patient here. So to compensate for the pressure difference, so how do you adjust the flows? Depending upon the organ that is being suffering a lot. If the patient is having severe heart failure, I need more flows on the artery side. If the patient heart is recovered, and if the patient, lungs are pretty much bad, that means I need more flows on the venous side. So by using this Hoffman's clamp, technically you can divert the flows here in a hybrid modality of ECMO here. And one more important, how do you measure the flows? So technically the output that is going on from a drainage limb is being diverted with a Y connector to artery and vein. So how you measure these two flows? You need to have two flow sensors. Okay, or else you can have only one flow sensor. Keep the flow sensor in the main limb, measure the flow, and then keep the flow sensor in either artery or the venous limb, measure the flow. The difference will be the other limbs flow here. Say for example, the main drainage limb flow is around 4 liters. And in my hybrid modality of ECMO, my artery is getting 2 liters. That means my vein is getting 2 liters. So that's how you can do it if you are using a single flow sensor. If you always two flow sensors, yes, that's a luxury here. So now see this diagram here. So they kept the flow sensor on the common limb here and they partially clamped the venous side so that more blood technically goes onto the artery side here. So because of the resistance, generally artery side less blood will go. By clamping here, by increasing the resistance on the venous side, you're diverting the blood more into the artery. So one more important technical challenge for ECMO physicians is increased requirement of heparin. Because there is a lot of connectors in the circuit, because there is an increase in the length of the circuit, your consumption of anticoagulants do happen, your consumption of blood cells do happen, more chances of hemolysis, more chances of flow disturbances, more chances of clots, more chance of heparin requirement to maintain your higher ACTs. So when there is more chance of heparin requirement, more chance of complications. So as I'm telling earlier, you require more characters, you require the higher risk of bleeding during cannulations. So always make sure that you are measuring the flows in both the cannulas. So you might be end up in undiscovered clot formations, tube kinking in unmeasured cannulas. Flow disturbances usually do happen. So make sure whatever might be the condition of the heart or the lung, at least 1 liter of flow should be there in each limbs here. So that's the major take home message here. So management, how do you manage? Again, the same thing. Once heart recovers, and lung times takes the time. So switch off from VVA ECMO to VV ECMO, and from VV ECMO you can wean off the patients. So make sure the flows you are measuring on both sides. Don't forget to measure the flows. You have to increase the ACT. So this is the last slide of the presentation here. So you have basically two ECMOs, VA ECMO, VV ECMO, a hybrid ECMO, VAV ECMO. So during the initiation phase, these are the various modalities which we generally have. And then the conversion during the run phase, you can convert a VA to VAV or VV to VVA, whatever might be the thing. So let us see the whole summary of the presentation by this point of time. So you have let us see the VA ECMO during initiation. The patient develops a North-South syndrome, then you convert it into a VAV ECMO. In a VAV ECMO, what are the various modalities based upon the configuration? You can have two femoral drainage vessels, VV-VA. Okay, that's called as that's basically both heart and lung failure situations. So additional drainage cannula has been given up here. So two drainage cannulas and then two return cannulas, VV-VA. So again, it's VLA-A. That means drainage from the LA and drainage from the vein here and return to the artery. Situations like cardiac stunning and with LA vent, these situations can be done here. And let's see V-APA. Again, it's a VA ECMO. One more written cannula was placed in the pulmonary artery, situations of right ventricular failure or pulmonary hypertension. Let's see this configuration here, VV ECMO. So once the VV ECMO patients develop cardiac failure or right-sided heart failure or pulmonary hypertension, you convert into VVA. In a VVA, what are the various submodalities we have? We have VPA. That means venous drainage. You have written into the jugulars and then written into the pulmonary artery also. So situations like again right ventricular failure and pulmonary hypertension. So you have VV-LA. Drainage is from the venous drain and then written into the femoral vein and then one more written into your LA. Situations like refractory hypoxia, RV failure and pulmonary hypertension. So one more situation as I'm telling earlier, VV ECMO with atrial septostomy. Drainage is from the femoral vein, written is from the femoral jugulars, but you did just a atrial septostomy. Situations like refractory hypoxia and right ventricular failure and pulmonary hypertension warrants this kind of ECMOs here. So based upon the technicality, based upon the expertise your center is doing, based upon the availability of cardiac surgeons, you can choose different modalities of hybrid ECMO. And based upon the indication, I mean, the patient has been going on through here. Just to summarize my presentation, hybrid modes of ECMO are uncommon, but they have more flexibility and possibilities during the initiation phase itself. They support both heart and lung. The future is of hybrid mode of ECMO because in view of late referrals, which we generally get patients from from primary care centers or secondary care centers, you will always receive the patients in multi-organ failure. So initiation wise, hybrid mode of ECMO is going to be the feature here. But don't forget that it's always patient tailored. So in medicine, there is no hard and fixed rules here. It should be tailored to patient basis. And stepwise approach is much more important here. Pulmonary artery, right ventricular support, and LV venting will be more frequently utilized in coming generations. As the interventions goes up, yeah, you might see more pulmonary artery cannulations and LV ventings can be done. So always go for mostly because it's a hybrid modality. It should be a percutaneous or minimally invasive approach here. So that's the basic nomenclature of ECMO and hybrid ECMOs here. Coming to the issues, yes, we need to add one more cannula. So placing a cannula on a hypernized patient, it's technically challenging. You need to have a good surgeon in your friends list. Otherwise, you'll end up in complications. You are adding an extra circuit or a new circuit. Again, the chances of SIRS reaction is pretty much high. Bedside complexity. Once you are in a hybrid modality of ECMO, you need to have a perfusionist who is well trained or you need to have a ECMO nurse who is well trained with these flows and well trained with these complex issues. Application depends upon the local experience, as I'm telling prior. So you should have an expertise to go ahead with these kind of hybrid modalities of ECMO. And they should have a proper cardiothoracic and vascular center also. You can do it without that. But if you do it with the help of CTVS guys, yes, your patient is much more safer here. Thank you so much, guys, for your patience understanding. Any questions? I'm happy to answer all your questions here.